Hello. Let's look at a topic which is really important from the first year point of view, NEET PG point of view, and as well as USMLE point of view. The topic is quite simple and scoring, so it's a must to understand this topic. And I'm sure you all have guessed it, and it's obvious that it's flexor and extensor retinacula that we are going to talk about. So what is a flexor retinacula? What is an extensor retinacula? Well, they are just strong bands of fibrous tissues and fibrous fascia, deep fascia, that holds the long flexors and the extensor tendons, right, in its position that it is supposed to be in its position. How it does that? It creates these fibrous septas, as we all know, which keep these tendons very specific to the location that they are, and that is literally how it actually kind of makes sure that each of these tendons are going to one of those particular digits, right? And without much ado, let's just directly jump into the flexor retinacula. Okay, so flexor retinacula, as you can see, and we're going to annotate as I speak, is going to be a fibrous band, right? A fibrous band, which is this green band that we can see, starting from the hamate. H is for the hamate, right? Absolutely. Okay, so medially, here is the medial aspect. It is attached to the hamate, and obviously it is also attached to the pisiform bone. Okay, obviously this bone that is drawn here is hamate only, but the pisiform bone is also giving a certain amount of attachment to the flexor retinacula. And laterally, it is laterally where we've got the thumb, right? Laterally where we've got the thumb it is attached. Okay, it is attached to two bones. Again, one is your trapezium, right, and the other is that it is also attached to the tubercle of, it's also attached to the tubercle of scaphoid. Tubercle of scaphoid. All right, so we've kind of understood where it is attached, right? Now we need to understand what each of the tendons, which tendons pass through. Okay, so within the flexor retinaculum, that I would say is inferior to the flexor retinaculum, we've got two major tendons that we have to know that pass through. Okay, first set of tendons like these are flexor digitorum superficialis. All right, they are flexor digitorum superficialis. What those tendons are, I'm assuming that people already know about. These are the tendons that go to the digits, and they are called superficialis because they are more superficial, right? On dissection, they are more superficial. So the one that is deeper is called flexor digitorum profundus. Flexor digitorum profundus. Flexor digitorum profundus is not only deeper, but it also goes more distally to each of the digits. And again, this is of very important clinical knowledge, that flexor digitorum profundus is one of those muscles that have about the nerve supply about these muscles is that they have two nerves, right? And that is something that everyone, I am hoping that people know about it, right? The medial half is obviously by the ulnar, and the lateral half is obviously by the median nerve. Then this specific muscle, right, that is a muscle called as palmaris longus. Okay, now something about palmaris longus can be absent in 10% of the population. Does that matter? Actually not really, because it is a weaker muscle and it only produces very weak flexion, and it's more of a stabilizing muscle. So its absence does not make a difference, correct? Then on the medial side, again, we have this one specific group of muscles. It's not just one muscle, but it's a group of muscle, and that we'll talk about in some later videos. It's the muscles of the hypothenar eminence. Okay. On the lateral aspect, we also have another group of muscles which is of the thenar eminence, right? So we've kind of covered a few muscles here and there. Now there are two other tendons that are very important that have to be noted, that lie inferior or deep to the flexor retinaculum, and that is the first one here, as you can see, that is flexor pollicis, so that's P, and longus, flexor pollicis longus. All right, so that is one muscle. The other muscle that lies here is flexor carpi, flexor carpi radialis. Okay, so this one's your flexor carpi radialis, FCR, and this one's your flexor pollicis longus. Okay, so in totality, the muscles that lie inferior to the flexor retinaculum is going to be flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus, and flexor carpi ulnaris. Then let's look at the nerves that lie deep to the flexor retinaculum. Is obviously the very famous nerve that we know of is the median nerve, right? The one that lies above here is a branch of the median nerve, which is nothing but the palmar cutaneous branch of the median nerve, right? So we got that. Then here we've got something called as ulnar nerve. So ulnar nerve actually is very superficial to the flexor retinaculum, and it passes through something called as a Guyon's canal. Let me just write it at the side. It passes through Guyon, Guyon canal, right? So it passes through Guyon canal. It does not pass through the flexor retinaculum or inferior to the flexor retinaculum. Also with the ulnar nerve, we've got the ulnar artery, super important, and we've also got the same palmar cutaneous branch of the ulnar nerve, the one which is crossed, right? The cross is the palmar cutaneous branch of the ulnar nerve. So having covered that, we kind of know everything that is lying in the flexor side, right? The flexor retinaculum. Now let's have a look at the extensor retinaculum. The extensor retinaculum is again a thickening of the deep fascia, right, which extends medially, right, again medially from the hamate and pisiform, right, as the image shows, and laterally, right, as you can see that the retinaculum is going all the way till here, which means that laterally it is attached to the radius. Okay, so that is interesting, right? It's not attached to the trapezium or the scaphoid, but it is attached to the radius laterally, which is different from what we had seen in flexor retinacula. Now the extensor retinacula that we are talking about, right, it divides it into 6 compartments, and let's look at the muscles in each compartment from medially to laterally, right? Now medially we have the first extensor, which is called extensor carpi ulnaris. All right, because it's on the ulnar side, it's called extensor carpi ulnaris, as simple as that. Then we've got the extensor digiti minimi. Simple. All right. Then we've got this entire group of muscles, right, from here. They are your extensor digitorum, and they kind of are the corresponding equivalents to flexor digitorum superficialis, but like the extends in the extensor compartment, right? Also, we've got another important muscle here, which I have highlighted, which is in the third compartment itself from the medial side, is your extensor indicus. Okay. Next muscle that we have are the muscles towards the radial side and the muscles of the thumb, for obvious reasons. So the first muscle here we've got is extensor, obviously, pollicis. Okay. In case we can't read it, I'll write it here. Pollicis longus. Okay. So extensor, pollicis longus. Then we've got a set of muscle, okay, and they are, again, because they are at the radial aspect, as logic suggests, it's extensor carpi radialis longus. This one's your longus, and there is a brevis. As simple as that. Okay, so longus and brevis. Very important. Alright. Then the last two muscles that we see over this aspect. Right? The last two muscles that we see here are the other muscles called as extensor pollicis brevis. We saw an extensor pollicis longus here, correct? This one's your extensor pollicis brevis, and this one's your abductor pollicis longus. Okay, so we've covered the muscles, right, that are in the extensor compartment. Just to recap, from medial aspect, we've got extensor carpi ulnaris, for obvious reason. Ulnar, we want to think as the medial most. Then we've got the digiti minimi, right? Again, on the medial aspect, we've got in the center, we've got the extensor digitorum and extensor indicis, right? Because in the center, and then we start with the pollicis and the carpi radialis. So we've got the extensor pollicis longus, then the carpi radialis, which could both longus and brevis in one compartment, and then we've got the extensor pollicis brevis and the abductor pollicis longus as the last compartment. Okay, this is something that we have to learn. Along with that, we've got an important artery, a very important artery, which is obviously your radial artery, right? We've got the radial artery. Very important thing again is that we've got certain veins, very important veins, and on the medial aspect usually we have obviously the basilic vein, and on the lateral aspect we have the cephalic vein, right? Along with the cephalic vein, we've got these two nerves, and these two nerves are nothing but they are the superficial palmar branches of the radial nerve. Okay, so we've got that done as well. I'm sorry if it has been a little more untidy, but we've tried to squeeze in how much ever we can. Okay, so we've covered most of the stuff. Now let's just look at the few questions that we have. So flexor retinaculum is attached medially to what? It's medially attached to obviously hamate and pisiform, that is already written here, and laterally it is attached to trapezium and the tubercle of scaphoid. That means there are two answers here, right? Okay, flexor retinaculum corresponds to dash transverse crease. It's your distal transverse crease. Really important. Extensor retinaculum converts distal end of radius into how many tunnels? Let's count it. 1, 2, 3, 4, 5, 6. Obviously 6 tunnels. You should know which tunnels have what as the content. Extensor retinaculum medially it is attached to obviously hamate and pisiform, and laterally it is attached to the radius, whereas the flexor retinaculum is medially attached to again hamate plus pisiform, but laterally It is attached to the trapezium and scaphoid. Okay, last but not the least, the very important clinical aspect of it, which is asked heavily in USMLE and NEET PG, is carpal tunnel syndrome. Carpal tunnel syndrome is simple. It is because of severe wrist movement in typists, in people who are working in the office. A lot of people, a lot of your friends who write a lot, they also have a lot of carpal tunnel syndrome. Someone who rides the bike may have it. The nerve involved is usually your median nerve. Right, so let's just understand. Okay, just look at this. The median nerve is so close with a lot of structures around, right? You've got all the carpal bones here, and the median nerve is sitting here right underneath the flexor retinaculum. So it is kind of getting compressed by the flexor retinaculum and by the carpal, right, by the bones, right? So that is why it is so important that to know the anatomy. What area is spared? The area spared is, obviously, if you think about it, the median nerve supplies the median nerve supplies a lot, like it supplies the hand, right? And it also has a lot of supply more proximally. But a part of the hand which is coming from its more palmar cutaneous nerve, okay, so as you can see, there is the palmar cutaneous branch of the median nerve, and it goes above the flexor retinaculum. So for obvious reasons, right, the area spared is going to be of the palmar cutaneous median nerve. And which area is that? Well, that area is nothing but the thenar eminence. Okay, so that is something which is very important. What area is supplied by the palmar cutaneous median nerve? And that is the thenar eminence. That is really high yield. Okay, now let's say if someone actually does have CTS, what is the few things that we can expect? Okay, what is the few things that we can expect this patient to have? Obviously, he's going to have tingling, right? There would be paresthesia over certain regions, right? But the thenar eminence. And how would you relieve this? Well, to relieve this, right? To relieve this, we would have to make an incision in the flexor retinaculum, and we can decompress it, right? We can decompress it. So decompression is an important answer to relieve it. Okay. Also, is there going to be any muscle weakness? Think about it. Well, it's a lesion which is here at the wrist, okay, and it's at the wrist here, and all of these FDS, FDP, all of the muscles, usually they are getting the nerve supply more proximally, not this distal. So obviously you have to think about that there is going to be almost nil, right, of muscle weakness. There's going to be no muscle weakness. So that is again super important. Muscle weakness, no. Why? Because they get the nerve supply much more proximally. With that, I think we've covered almost everything that's required in the flexor and the extensor retinaculum. With it, even it's carpal tunnel syndrome, which is super high yield, where you have burning pain along the distribution of the median nerve, which is the lateral 3.5 fingers, right? Okay, and a very important question would also be, because we spoke about muscle weakness, is there going to be thenar muscle weakness? Thenar muscle. Absolutely. Because the thenar muscles are distal to the median nerve at the wrist level. So there's going to be thenar muscle weakness. However, there's not going to be any sensory loss over the thenar eminence. So CTS, if I had to write it down, I would write it down as thenar weak but sensory good, fingers sensory bad, but muscles good. And in this closing statement, thenar muscle weak but sensory good, finger sensory bad. And by finger I mean only the lateral 3.5 fingers, but muscles are fine because those are supplied more proximally. With that, I take your leave. If you liked it, please like and subscribe.